The second case is a 62-year-old morbidly obese patient who is advised cholecystectomy for frequent bouts of right upper quadrant pain secondary to long-standing cholelithiasis. So if you look at his past history, he had an ACS, that is inferior wall MI, 7 months ago, where he was treated with 2 drug-eluting stents in the proximal to mid part of the RCA. And again, after 2 months, he had an again recurring episode of chest pain, where ECG was taken, where there were STT changes, and again, the cardiologist was called, angiography was done, which showed that there's some amount of stent thrombosis in the proximal part of the RCA. So the cardiologist did his job. He did a thrombectomy, did a balloon angioplasty, and imaging was done as usual to understand whether there is some expansion, under expansion or not. After that, he has escalated clopidogrel to a more potent antiplatelet, that is prasugrel, which is much more potent when compared to clopidogrel. So with this, the patient was discharged, and again, after some time, patient again presented with a bout of cholecystitis. At the time, the surgeon advised laparoscopic cholecystectomy with an option of open if required, taking into consideration the multiple comorbidities. The risk of bleeding is very high for this patient. He has explained both the ischemia as well as the bleeding complications for that particular patient. So after a review of all these findings, these are the different options. I think we'll come to at the end of the discussion. So taking these 2 scenarios, I think these kind of complex scenarios you do come across in normal day-to-day practice. So whenever you see a patient of post-angioplasty, the 4 important things what we need to understand is, first to know what type of stents they have been implanted, whether it's a bare metal or drug-eluting stent, what antiplatelet patient is taking, whether it's taking P2Y2 inhibitors along with ecosprin or some other drug, and proper evaluation of the patient is very important. The 4th one is how we are going to manage. So these 4 points I'll be discussing in detail. So coming to the incidence of that is a non-cardiac surgery. So in a patient after PCI, the frequency of the non-cardiac surgery is around 4%. It may vary from center to center, but in big centers it may be around 20% also. And if you look at the MACE event rates compared to a patient who had not an angioplasty, a patient who has undergone angioplasty, there is a 2-fold increased risk of having a MACE events. It could be a myocardial infarction, it could be a stent thrombosis, or it could be a cardiac death also. So that is why if you see a patient of angioplasty, the 4 most important points has to be kept in mind. The first one is time of onset from the PTCA was done. So if the patient has undergone angioplasty in the recent past, like within 1 month, the chance of getting a stent thrombosis is always high than when compared to a patient if the angioplasty is done 6 months or 12 months before. So that is why the timing is very important. Second one is what type of stent. Like I said, bare metal stents are out of use. Now we are using more of drug-eluting stents. And the location of the artery. Suppose you do an angioplasty for a proximal LAD or a left main or a bifurcation or a long metallic stents are implanted, then the chance of having a stent thrombosis is very much higher. So that is why the location is also equally important. And indication, like I said, if the patient is taken for ACS, for primary angioplasty, if you stop the antiplatelet, then the chance of stent thrombosis is much more higher than when compared to an elective PCI. And if the patient has any event during the recovery or in the follow-up period, like in the second case we saw, patient had a recurrent ischemic event, then the chance of having a stent failure is much, much higher. So always the complications of stent thrombosis, the bleeding risk, the MACE event rates need to be considered. So if you look at the type of stents, as you know, bare metal stents are out of use. DES is the norm now. So the first generation were sirolimus and paclitaxel, which has been now been escalated to zetolimus and everolimus stents. And latest we have the biodegradable scaffolds, which are also there into the market, which is being used for many of the patients. So this is the routine picture which shows the angioplasty procedure, how in the cath lab we put a wire, we do a balloon and put a metallic stent across. So etiology of stent thrombosis, as in the first case which I showed, withdrawal of antiplatelet, like non-compliance with the antiplatelet is one of the strongest reasons for stent thrombosis. And of course, complex lesions like bifurcation lesions or a patient who have a long metallic stents, the chance of stent thrombosis is very much higher. So we need to re-stratify the patient, whether what risk the patient is falling. That is most important. So both the consideration like the surgical risk, what type of surgery the patient is undergoing, and of course the patient risk also has to be kept in mind. Surgical, if the risk is less than 1%, you call it as low surgical risk. There's a lot of list there, starting from dental procedures, breast surgeries, gynecological minor surgeries, all comes into low surgical risk, which is less than 1%. And 1 to 5% falls in the intermediate risk, where especially the renal transplants, the head and neck injury, the TIVAs comes into that category. The high surgical risks are always the vascular surgeries. So abdominal aortic surgeries, abdominal aneurysms, liver transplants, pulmonary transplants, all comes into the high risk category. So if the patient is having a bigger surgery, like a vascular surgery, the perioperative risk will always be higher.